suffering a lupus his abdominal wall is, anyway. I think we're getting people. Are we have enough people? Do we have Cora?
Hi there.
สวัสดีค่ะ Justin.
Hi there. Hi,
Justin,
Jenny. Hi,
hello.
Diana.
Hi, I
Good,
think
how are
we
you,
have
sir?
enough people now. So if you
Okay.
want to start at any time, please
Okay.
do.
Okay, let's get started. It's 5:03. So good morning, everyone who is in Thailand. Good morning and welcome to our April meeting. Our guest speaker today is somebody who you have met last year. He talked about radiation treatment in rectal cancer. And today, Dr. Nima Nabavizadeh, who is an associate professor at the radiation medicine. And he's absolutely superb. A clinician, researcher, just everything, and a leader in the field. And he'll be talking about different ways we can really implement TNT, and when we make decisions of which pathway to take before we go for surgery or if we are planning organ preservation. So Nima, thank you. And I know you send your slides and I cannot wait to hear your talk.
Sure, thank you. Thanks for that wonderful introduction. Thanks for the invitation to speak. Just in full disclosure, I'm actually clinical right now. We're doing a couple after-hour treatments, so I may get paged to check some patient treatments, which will take me 2 minutes. So I may get paged twice, and I may have to leave for 2 minutes, 2 different times in this hour. So excuse me if I have to do that. I apologize. I will share my screen. All right. Your faces on the right screen. Okay, good. Well, thanks again. And yeah, hopefully I'll be able to color all the different ways that we're treating rectal cancer in 2025. As a resident, neoadjuvant treatments for GI cancer, specifically rectal cancer and esophageal cancer, was quite a bit straightforward, honestly, with minimal alternative regimens to choose from. Which made training quite easy, which made oral examinations a little easier. So for our trainees now, there's a lot of different options, a lot of different studies they have to digest and know, which is not a problem because what it means is providing more personalized treatment for our patients with locally advanced rectal cancer, which we all recognize as a outstanding thing. Here are my disclosures. So as far as our learning objectives, we'll compare and contrast different radiation regimens, since I'm a radiation oncologist, which will go into the different neoadjuvant protocols. So it's important to have a good understanding of the definitions behind them. We'll really briefly look through the historical data of neoadjuvant treatments and then understand the newer approaches of total neoadjuvant therapy. We'll talk about the latest data on non-operative management and selective omission of radiation. So goals for treatment for our patients are, one, to prevent distant metastatic recurrence, which we do with systemic therapies. And we also want to prevent local, regional, pelvic recurrences, which we do with our local therapies, which include radiation and surgery. And with all of these goals in mind, we have multiple ways to individualize therapy for our patients. And I'll run through the data that supports this and then kind of give you my take of where I think everything fits in. So as far as definitions, we have in the radiation therapy realm, we have long course and short course radiation therapy. Long course refers to daily treatments of 1.8 to 2 gray per day over 5 or more weeks to a total of 50 gray or more with concurrent chemotherapy commonly. Short course radiation pioneered by our European colleagues are daily treatments of 5 gray per day over 5 days to a total dose of 25 gray. There's some newer studies looking to push that dose even more, both on the long course chemoradiation end as well as the short course radiation dose regimens. And we'll talk about some of the dose escalation studies later on. I think it's important to notice that radiation treatment volumes between these two regimens are largely incredibly similar, where we're treating the primary tumor plus the mesorectal lymph nodes, plus the lateral pelvic lymph nodes, plus the presacral regions. And for T4 cancers, we extend our volumes and cover the external iliacs as well, T4 with organ involvement to cover for any anterior involvement of the external iliac. So, and we design our fields pretty much the same, whether we're doing short course or long course chemoradiation. The differences are just in the doses prescribed. So the classic study, the Swedish rectal cancer study, originally published in '97, updated in 2005. This has been to date still the only randomized study showing a survival advantage to the addition of neoadjuvant radiation to surgery. This is largely because this was a pre-TME era surgery where these were blunt dissections and not what we consider now standard of care TME. So likely the radiation was doing some cleanup work, hence the survival differences and benefits to the radiation. The Dutch trial was the first randomized TME study, the more standard of care surgery that we're providing now for all of our patients. No survival benefit to the addition of neoadjuvant short course radiation here, but there definitely was a local regional benefit to the addition of radiation. And, local regional improvement, although, doesn't, as far as we know, go into the survival of these patients, is still an important endpoint because pelvic recurrences are incredibly morbid. And if we can minimize those, certainly it's for the best. The German study, which is another benchmark study for rectal cancer, randomized neoadjuvant to adjuvant long course chemoradiation therapy, showing no overall survival benefit to the addition between the two regimens, but there was a local regional benefit to the neoadjuvant regimen, and there was also famously increased sphincter sparing surgeries in the neoadjuvant arm. So, these studies in total have kind of led us to the modern era of neoadjuvant radiation for rectal cancer. There's been some studies comparing neoadjuvant short course versus neoadjuvant long course radiation therapy. In general, not a lot of perceivable differences as far as oncologic outcomes. This Australian study identified a trend to increased and improve local regional control for distal tumors, so low tumors that received long course radiation therapy. Again, as a trend was not significant, but no substantial differences. The Stockholm 3 trial was a randomized study that incorporated pre-op radiation, both short course and long course radiation randomized. Didn't show any differences between the radiation regimens, and certainly and importantly showed that a delay of surgery for the pre-op patients that received the short course, a delay of 4 to 8 weeks as compared to the historical standard of having surgery immediately after the radiation, was largely the same without additional complications, which really provided a lot of logistical flexibility for our team. Before the Stockholm 3 study, we tended to go, to the specific regimen of either the Dutch study or the Swedish study, where we did the pre-op radiation and an immediate surgery the following week, and that can really be challenging to coordinate, multiple different specialties to make something like that happen. We did make it happen, but this Stockholm 3 study really has provided us comfort that we can delay surgery up out to 8 weeks after pre-op short course radiation therapy. As far as toxicities between short course and long course, I think it's important to note that both the Polish study and the Tasmanian study, these were studies that did the surgery immediately after short course radiation. So it's not surprising that acute grade 3 toxicities from radiation were less in the short course arm as compared to long course, because the rectum largely had been surgically removed. But looking at more modern studies of this comparison, such as the Rapido study, which we'll talk about later, comparing toxicity of the long course and short course, there's certainly, in my experience, is a little more proctitis that we see a couple weeks after short course radiation that can sometimes surprise patients if they're not aware of it. During the week of radiation, we get the dose in so quickly that the cumulative radiation toxicity really hasn't presented itself while the patient's in our clinic. And it's really in the couple weeks afterwards that they are certainly noticing clinically significant proctitis and discomfort and dyschezia. And what I aim to do in patients who get short course radiation, many of them are getting chemotherapy after short course now based on the Rapido study, which we'll talk about. I make sure that proctitis has resolved because, the worst thing is for somebody to be at the pinnacle of their proctitis from radiation, and then you're starting FOLFOX chemotherapy, adding toxicity on top of that, and that can be quite intolerable. So, our medical oncology colleagues are pretty great about potentially delaying chemotherapy by a couple of weeks to allow that short-term proctitis from short course radiation to resolve. This ushers us into the modern era of total neoadjuvant therapy. Preoperative short course or long course chemoradiation has been very effective at decreasing pelvic recurrences to around 5% long term, which is great. However, distant metastases are still a large problem, which we see in our patients in our clinics. And 6 months of adjuvant chemotherapy has historically been recommended, even with pretty scant evidence and support for its use historically. With adjuvant treatments, whether it be for any GI cancer, whether it's rectal or esophagus, many patients don't complete the postoperative chemotherapy due to the toxicity associated with it, especially as they're recovering from a large surgery. And moving chemotherapy from the adjuvant time point to the neoadjuvant time point before surgery may help improve tolerability, may help downstage patients and make those that might be surgically unresectable or those with threatened margins potentially more surgically resectable. It may also help improve path CR rates, and there are loose correlations with path CR rates and long-term survival. So the Spanish GCR3 study was a randomized phase 2 study that looked, and one of the first ones that looked at CAPOX either before chemoradiation or after surgery. So it was one of the first neoadjuvant studies showing similar pathologic complete response rates when they remove the chemotherapy to the neoadjuvant setting. But they did see that induction chemotherapy was less toxic and better tolerated than the adjuvant arm. The timing study from Julio Garcia Aguilar, MSK, and the timing consortium also looked at this approach of moving the chemotherapy from the adjuvant to the neoadjuvant realm, and looked at different groups of increasing the amount of chemotherapy in multiple groups, from 2 cycles to 4 cycles, and in group 4, 6 cycles of FOLFOX chemotherapy after neoadjuvant chemoradiation and before surgery. And what they found, not surprisingly, is that the more chemotherapy you're able to provide in the preoperative setting, the higher rates of pathologic complete response that you'll see with up to 38% pathologic complete response with the group that had the most amount of chemotherapy preoperatively. The Rapido study was one of the more robust comparisons, randomized comparisons of our traditional trimodality therapy of pre-op chemo RT, surgery, adjuvant chemo, and total neoadjuvant therapy, meaning radiation and chemotherapy before surgery. The Rapido study compared short course radiation in the total neoadjuvant arm, 5 grade times 5 short course, and long course chemoradiation was included in the standard arm. And they found that the total neoadjuvant arm had less 3-year treatment failures, which was statistically significant, better pathologic complete response rates in the TNT arm. And on a post hoc analysis, and this is just kind of as an aside, they found that the patients that had the long course chemoradiation in the standard arm had actually more local regional failures than the ones that, the ones that had short course radiation had more local regional failures than the ones that had long course chemoradiation. And this is data that we're utilizing to potentially, not in a kind of standard way recommend short course for everybody, because there is data that shows that potentially we're sacrificing local regional control by providing patients with short course radiation. But this didn't play into the overall treatment failure, which was improved with the total neoadjuvant therapy. So, I mean, my takeaway from the study is that total neoadjuvant therapy is definitely more ideal than standard treatment. but we should replace the short course arm with long course chemoradiation. The PREDIGE 23 study did something very similar, randomizing standard treatments to total neoadjuvant treatments with a improved 3-year disease-free survival with total neoadjuvant treatment and better path CR. A question that comes from all this now is, can we selectively omit one of these treatments to try to minimize the morbidity of radiation, to minimize the morbidity of surgery? Radiation in certain populations can cause a lot of proctitis, long-term, I think an underreported long-term side effect of radiation or pelvic insufficiency fractures, which, I think can happen in up to 25% of our patients. And these sometimes can be quite debilitating with minimal treatment options available. Certainly vaginal stenosis risk for sexually active women. So certainly, do we have an approach to omit radiation if you're going to have a planned surgery? The UK Mercury study was a non-randomized straight to surgery study that essentially for low-risk tumors identified an excellent 5-year local control of 95%, which was similar to the studies that utilize radiation in the neoadjuvant realm. And this ushered in the next study, which I'll talk about, the Prospect study, which made a lot of press in the U.S., particularly in the New York Times. Many radiation oncologists quite a bit disagreed with the title and the tone of this article, really painting radiation therapy in an incredibly negative light that needed a little bit of kind of measured approach to it. Irregardless, it was a very impactful study, which was the Prospect study, which is looking at the selective omission of radiation for patients that respond to neoadjuvant chemotherapy. And this is for locally advanced rectal cancer patients, randomizing them to standard arm, which is chemo-RT, surgery, adjuvant chemo, or the selective arm, which was the selective omission of radiation for patients that had a greater than 20% response to neoadjuvant FOLFOX. Of note, about 90% of patients that were randomized to this arm had the response and were able to avoid the radiation, meaning, a very minority of patients do not respond to this neoadjuvant FOLFOX, but still it's an important thing to check and measure prior to omitting the radiation per the Prospect study. And essentially, the study showed a non-inferiority to a selective in chemotherapy alone approach in the neoadjuvant setting for locally advanced rectal cancer patients. What's incredible is that the local recurrence rates 5 years out for patients in either arm was in the 98% realm. So incredibly optimistic and really a incredibly needle moving study that really is providing patients who are looking to spare the morbidity of radiation an evidence-based approach that can certainly be meaningful for certain patients. The pathologic complete response rates for this first column is the chemotherapy arm, and the standard arm was quite fantastic. It was 24% pathologic complete response rate to chemotherapy alone, and wasn't statistically different from chemoradiation alone. Side effects wise, there certainly were more hematologic toxicities in the FOLFOX arm, more diarrhea in the chemoradiation arm. Largely quality of life trends didn't have any significant differences between the groups, but there was some bowel and sexual function that favored the FOLFOX group. So this study is basically the benchmark study providing supportive evidence for the selective omission of radiation for mid to high rectal cancers without threatened margins that don't need radiation, who get chemotherapy alone and have a good response to chemotherapy. Now, another question is for many folks, especially patients with low rectal cancers who may be left with a permanent colostomy after an APR, do we need surgery if we have a complete clinical response to total neoadjuvant therapy? This is the International Watch and Wait database that was published in 2018. It's a pooled analysis of multiple centers that had been pioneers in a watch and wait approach for locally advanced rectal cancer. Nearly 900 patients enrolled, largely from centers in Brazil, Netherlands, and the UK. And as far as the regimens that were used in this watch and wait approach, the vast majority of them had single therapy. This was an era of patients enrolled in, the mid 2000s to 2010. So total neoadjuvant therapy hadn't really hit the vernacular yet and wasn't provided in any kind of robust way. But even with single therapy, the proportion of patients with local regrowth after treatment was about 25%. So, which is quite impressive that nearly 75% of patients were able to get away with a watch and wait approach in this pooled analysis, and the overall rate of distant metastases was quite low and consistent with other kind of prospective studies. And this brings us to the era of the OPRA study, a very impactful study published in 2022, which at OHSU, we were the second leading enrolling site after Memorial Sloan Kettering on this study and early adopters of this approach. This was a randomized controlled study looking at the possibility of non-operative management for complete clinical responders. The randomization in this study was not a randomization to watch and wait or immediate surgery. The randomization was to, in the total neoadjuvant treatment period, which treatment do you provide first? Do you provide the long course chemoradiation first, or do you provide the chemotherapy first? And which one is better for folks? And that was the first randomization. And then after patients received either one of those randomized treatments, they were restaged. And those that had a complete clinical response underwent watch and wait approach, and those that did not went to standard of care surgery. And this right here are the disease-free survival rates of the patients in the OPRA study, which were very consistent with other historical studies showing about 80–85% DFS. And then what's notable is the organ preservation rate was improved and better in the arm that was considered the consolidation arm. And that essentially is the arm that received chemoradiation first. So the consolidation refers to where the chemotherapy landed. So for patients that received chemoradiation and then chemotherapy, organ preservation rates were 58% compared to those that received chemotherapy, then chemoradiation, where the organ preservation rate was 43%. So this is a watch and wait study, and the most robust and still the only prospective one that looked at long course chemoradiation therapy. I think it's a totally reasonable question next to ask: can we get similar results with short course radiation therapy, really truncating the amount of treatment that these patients need from 6 weeks of radiation to 1? This was a retrospective study from the Washington University, looking at short course radiation and then chemo and then non-operative management for complete response patients. And they had similar clinical complete response rates of about 50%. Certainly is a study that helps provide numbers for prospective studies. The short FOX study, which was just presented at ASTRO, this is the American Society of Radiation Oncology. This was presented at ASTRO at the last annual meeting, and this was a single arm phase 2 study combining short course radiation to a total of 30 gray, so a little dose escalated from what we traditionally do, and intensified chemo as well, full FOXIRI for patients with locally advanced rectal cancer or low rectal cancer. And they enrolled 37 patients in the study, and out of that, 18 were managed with organ preservation, and 9 of those had sustained clinical complete responses, meaning that the 1 and 2 year clinical complete response rates were about 24%. I think what's notable is that there were no patients with T4 disease that had a clinical complete response rate. And this is something that I know that we're hoping for in tumor board for many of our patients with very advanced T4 disease, hoping that they may not need that aggressive surgery, that may need to remove the bladder and vaginectomy and things like that. But unfortunately, we're starting to see data that these T4 patients just are certainly a different biological subgroup, and it's challenging for us to get them into a clinical complete response. A question that we ask in every disease site in radiation and have been historically for the last 100 years is, does more radiation dose mean better outcomes for our patients? Most centers treat rectal cancers to 50 to 54 gray. The OPRA study, which I presented, allowed an optional radiation boost to 55.8 gray. And actually, the Astro just presented a secondary analysis of that dose response, which I'll talk about. And there are approaches internationally of boosting radiation dose in a very local fashion with contact X-ray brachytherapy. And there's a substantial study from the UK looking at this approach. This is the Papillon device, which is not FDA approved in the US. It's available clinically in France and the UK, as far as I know. I'm unsure if this is available in Thailand. If anybody knows if this is available in Thailand, I'd love to know, and please speak up. But essentially, this is low energy X-rays that are provided in a kind of pseudo endoscopic way directly onto the tumor in a very kind of focused ablative fashion. And this usually happens after a pelvic radiation treatment. So that was the OPRA study, which was the non-operative management watch and wait study. This is the OPERA study, which is looking at a phase 3 randomization of dose escalation with a brachytherapy boost in addition to pelvic radiation. So in this study, all patients got pelvic radiation to 45 gray, and patients in the external beam arm received an additional 9 gray and 5 fractions boost. Those in the contact brachytherapy arm received 90 gray of radiation in 3 fractions over 4 weeks. So quite an aggressive dose of radiation. And those that had complete response were allowed to be followed in a watch and wait format. Again, this is from their ASCO presentation last year, showing how they do this this contact brachytherapy radiation. Tumors have to be less than 3 centimeters for them to fit within this applicator. So you can't do this for very large tumors. And impressively, they found an organ preservation rate of nearly 80% long-term with the utilization of this contact brachytherapy approach, as compared to 60%, which is closer to what we experienced on the OPRA study. So pretty remarkable results. And again, unfortunately, the Papillon device is not FDA approved in the US. However, there are centers in Montreal, Texas, and I think in New York who are developing high dose rate brachytherapy approaches, similar like we do for gynecologic malignancies, for a rectal boost. And I'm very hopeful one day this will be an approach that we may have to offer here locally at OHSU. We have a pretty robust brachytherapy department, and I can see a potential avenue there. Time check 5:30. So going back to the OPRA study regarding more dose, does more dose matter? This was always a question. I was a resident and an early attending when we had the OPRA study open, and this optional boost of an additional 9 to 11 gray always was something that, I didn't know what to do and was hoping that the protocol would just specify what we need to do, but it was optional. And I would say we probably lean more towards giving the aggressive boost for most of our patients. And that's what most people in the study did. They get, more people gave the optional additional boost of 56 gray total as compared to the standard 50 gray. Largely the groups that received either were the same, except for T3, T4 disease was more common in the high dose group. And as far as organ preservation rates, it's not that this study didn't really show that more dose helped with organ preservation on the OPRA study. So no great data that additional external beam radiation dose to 56 gray is beneficial, but certainly the OPRA study, the one I showed previously, showed that a endoscopic boost with some type of brachytherapy source is definitely impactful. So my take, kind of assembling all of this, and I certainly want to leave some time to allow you all to ask questions and kind of think of opportunities or different pathways, is that TNT is certainly at this point standard of care for all locally advanced cancers. I would say certainly at our institution. There are some institutions in our community that are still doing kind of a traditional adjuvant chemotherapy approach, but those are becoming more and more uncommon. Given the results of the OPRA study showing that there is increased organ preservation rates for patients that start with chemoradiation, for a run-of-the-mill locally advanced T3 or node positive patient, we're commonly starting with long course chemoradiation, 45 gray and 25 fractions, with a boost sometimes to 50 to 54 gray, depending on the provider. My hope is one day we'll have HDR brachytherapy available for us to further boost in an evidence-based way. And then providing the consolidation chemotherapy and then a watch and wait approach. And our common surveillance methods right now for a watch and wait approach are MRI and FlexSig. Both of them are incredibly important, equally important and kind of additive in our assessment of whether or not we should continue watching a patient or take them to an upfront TME. If a patient has no metastatic disease, but has imaging features that are worrisome for high metastatic potential, and I'm talking about things like extramural vascular invasion, a lot of pelvic lymph nodes, lateral pelvic lymph nodes, if they have indeterminate lung or liver lesions that we're worried could represent early metastatic spread. In those patients, my inclination is that starting with chemotherapy to get them, systemic therapy that they probably need due to this high risk is probably more impactful than starting with chemoradiation and giving them that potential 10% boost in organ preservation. So folks with a really high metastatic potential, we're usually starting with chemotherapy first. Given the Rapido study showing that short course radiation therapy patients had increased local regional failures, we're not commonly using short course radiation therapy in our total neoadjuvant approaches, except for patients that may have logistical issues who can't receive long course chemoradiation due to psychosocial reasons, or just an inability to stay in the Portland area for 5.5 weeks. Certainly providing short course is an evidence-based method of total neoadjuvant therapy, and really I have minimal pushback if a patient's looking for short course radiation. And then we discuss watchful waiting with endoscopy and MRI every 3 months. And now speaking of the, my experience personally, and I'd like to hear Dr. Grossberg and Kardosh and other people's experience, with the prospect study coming out, I tend to, and your experience too, Dr. Sikidis, I tend to bring up, especially for folks with those low risk mid to high rectal tumors who we could avoid radiation for, I bring up non-operative selective omission of radiation, which 90% of people can probably get away with. And unless they're a younger woman who is sexually active and or looking to preserve fertility, I've had minimal success convincing people to move away from radiation, but that might be me being a biased radiation oncologist and not presenting the options in the most fair way. So I'd love to hear your experience on that. But certainly selective avoidance of radiation for those concerned about fertility is 100% a reasonable thing. The last patient actually that still is weighing heavy in my mind actually started total neoadjuvant therapy and chemoradiation 2 weeks before the prospect study was published. So the prospect study was published in the middle of her chemoradiation treatments, and she was really hoping to omit radiation because she's 37 and hadn't had a child yet. And I unfortunately told her at that time, with the prospect study, they never even reported preliminary results. It went right to publication in England Journal. I had no evidence to say that we could omit radiation in her situation, and unfortunately, unfortunately, the prospect study resulted, and she was overall okay with an understanding, but we were a couple weeks too early for her. Just real briefly on early stage cancers, this is a lot of talk on neoadjuvant treatment for advanced stage cancers. For early stage cancers, there's approaches that are developing. This is the ACOSOC study looking at T2 node negative patients with tumors that are less than 40 centimeters, looking to see if we can get away without having to do a total TME for, for whatever reason, patient doesn't want it or patient not a candidate for larger surgery. This was a study looking at chemoradiation followed by local excision with a primary endpoint of 3-year disease-free survival, which was fantastic at 90%, showing that it might be considered in carefully selected patients who refuse or aren't candidates for TME. The NEO trial was looking to do the same thing, but not with chemoradiation, but with chemo. That showed a 80% organ preservation rate, kind of closely matching up to the ACOSOC study. And then here are the long-term kind of mature results presented at ESMO this last year. And then what the next step here is randomizing those two approaches, randomizing the NEO approach of chemotherapy alone in the local excision versus the ACOSOC approach of chemo-RT and local excision. This is the NEO-RT study that will hopefully be open at OHSU soon. So a couple case examples. This is a 64-year-old male patient of mine who was in assisted living center due to a traumatic brain injury, had memory difficulties, but otherwise good functional status. Had a positive fecal occult blood stool test and was referred to colonoscopy. And he was found to have a T2N1 tumor on imaging, and given travel difficulties, we provided short course radiation per the Rapido study, short course, then adjuvant FOLFOX therapy for 4 months. And we simulate our radiation patients prone commonly. When we treat them prone, it allows the bowel to fall with gravity anteriorly and out of the way to provide us some breathing room with our higher radiation dose in the posterior pelvis. And this is his short course radiation treatment. Looking at the isodose lines, this red line refers to 2500 centigrade or 25 gray. This is our prescription dose. And the radiation dose emanates in a kind of concentric way with lower doses in an outward fashion. And you can see here we're covering the mesorectal space, the presacral region, lateral pelvic lymph nodes, and down towards the anal canal. And then another example, case example, of 53-year-old healthy male presented with rectal pain and weight loss. CT with low rectal thickening, suggestive malignancy with EMVI and local regional nodal involvement, was T3 node positive by MRI. Had positive perirectal and internal iliac nodes, a 0 millimeter circumferential resection margin, had sphincter involvement. And given the high risk of metastasis for this patient with EMVI and lots of nodes, we started with chemotherapy and then moved on to long course chemoradiation. And here's his long course chemoradiation plan. You can see our volumes are largely the same. The main difference is that in long course chemoradiation, we treat the elective pelvic nodes, again, presacral, mesorectal, internal iliac, pelvic sidewall to 45 gray, and then provide a boost dose or slightly additional dose to the rectal tumor plus a margin to a total of 50 to 54 gray. And this patient got a total of 54 gray to the rectal primary. And I'm sitting right here right now. That's where I'm at. Thank you. I'll open it up to questions and discussion. Thanks.
Any questions?
I guess, Aaron, if you don't mind me putting you on the spot, if you're there, what's been your experience presenting prospect and selective omission of radiation with patients?
Maybe I get a different population than you. Maybe our schedulers are doing some biased screening or something, because my patients all walk in the room and they seem to be pretty worried about radiation. And so for those patients that are sort of upper, mid to upper, a lot of them like the idea. Sometimes I'm talking them back into radiation. But I found patients to be pretty receptive to it. I think if surgery, if they're okay with surgery and or if they prefer it, I think it's a totally reasonable approach.
Yeah.
since the advent of the TME, the benefit that we provide for a lot of cases, right, is really limited.
Yeah.
Right? If you look at the
In the setting of surgery, yeah.
right, in the setting of TME,
Yeah.
it's limited.
Sure.
Now for high risk patients, that's different.
Yeah.
But a lower risk patient, I feel very comfortable with it.
Yeah. I don't know, Kim and Liana, if you have any comments or thoughts on that. And Flavio.
I
Sorry.
think that for patients who want like a watch and wait, which is the majority of my patients, they want the radiation. They want a better chance of having to go away
Without surgery.
without surgery.
Yeah. And that's regardless if the surgery is an APR or LAR. I mean, certainly I would assume the APR patients are more invested to not having surgery, but you see that even with kind of like standard LAR patients too.
But I think there's also the patients are figuring out that with low anterior syndrome, there's a lot of quality of life problems with even if you preserve the anus.
Mhm.
So a lot of the patients are really push for they want to watch and wait.
Mm-hmm.
And it's easy to sell chemoradiation early, at least for my clinic.
I would say,
Interesting. So I was going to ask Thailand for their experience of the patient population in Thailand. What do they choose in terms of their preferences? Dr. Tiravud, are you with us on this? Can you hear us?
would have,
Yes. Usually,
I think you're back to mute, Dr. Tiravud.
in Thailand, we still not offer a wash and wait for the patient at this moment, but we give some information for them if they don't want to do the surgery.
Thank you. Sorry, Liana, I didn't mean to speak over you there.
no. Sorry, I had some technical issues with my computer. I couldn't unmute. The question that Nima is asking is, most of our patients want to avoid surgery. I mean, they know about watch and wait, and they don't want the morbidity of the surgery, particularly as Nima, you mentioned about a permanent colostomy. But the one thing I want to bring up is that the prospect trial was not the same like the rapido trial. Like the patient population, not only there were higher tumors, there were like T3, they were like much smaller. They were not the big and ugly tumors that we usually see here. And I find that it's limiting of what they examined and how they reached that conclusion that radiation is not needed, because it's not the same patient population that was examined among every single trial that we kind of show and discuss. So I think the prospect trial for a T3 and 0 upper rectal tumor, it would make sense to me to avoid radiation, but this is not the most common cases we see. So
Yeah, you're right. I mean, I unfortunately glossed over some of those inclusion criteria, which you're right is totally important. The Rapido study was a specific, very high risk population, honestly, a very, very, very different. You're talking about high risk on Rapido, low risk on prospect, and there's a lot of room in between, honestly.
I love that you touched the early stage rectal cancers, because everybody says, so you're telling me I can have a watch and wait approach if I'm advanced, but when I am a T1, T2, and we do discuss the neo, what do you think about the short course radiation treatment for those early cancers like the TREC trial?
Yeah.
And I mean, I know we don't have the Papillon. I don't know if Thailand, if any of the private hospitals have this machine. Maybe Dr. Thiravut can speak to it, but I am curious, like, would you offer the short course radiation treatment like the TREC trial? They did pretty well. Those patients did pretty okay.
Yeah, thanks for. And there's also, I think, a subsequent study, the Star Trek study, that I think is comparing long course to short course in the similar population to prove that short course is probably as as effective as long course. And I got to say, it's attractive. I can't say that I've clinically been in that situation yet to make this consideration, but you know, would entertain it for the right patient for sure.
And then the pelvic side wall, I'm very curious to see. Pelvic side wall, if we see them initially, we treat them within your radiation field. And then there is that question when they disappear. I want to hear our Thai colleagues, what do? Do they go after and do a lymph node dissection? Do they say it's not there any longer? Like, how do they approach that? Or, well, if they're persistent, I assume you do a lymph node dissection, but I would like to hear our Thai surgeons, how they approach that, because for us, it's still a kind of a conundrum. I don't know, Dr. Thiravud, I cannot see Jenny. You have to help me.
Yes, he's on.
May you repeat your question again, Professor Rina?
So what would you do when you see pelvic, like the lateral pelvic wall nodes, positive for rectal cancer? You treat with chemoradiation and you go for surgery. And if they have disappeared, would you go ahead and do a lymph node dissection or not? I'm just curious how you approach that after they have received radiation treatment.
Usually, we try to dissect the lymph node at the first diagnosis, because we are not sure that even the imaging show that it's good response, but pathological we have to prove them. But it depends on the surgeon that they can do the lateral dissection or not.
Okay. So you would do it no matter what, even if he was showing after your radiation treatment, if they are treated, like they're not there anymore, you would still do a pelvic wall site. I mean, this is what
just a picking, not the systematic dissection of the lymph node.
Okay. I see. We don't have a consensus. I mean, I was just curious because we don't have a consensus in our institution, and we always will discuss it in tumor board, but we don't have a consensus.
Speaking of consensus, it's a good time for me to jump in?
Oh, please, Flavio.
And I just want to say here, I'm in the office here. I have Dr. Iron Pires here, who's a Brazilian HPV transplant surgeon who's visiting us from Sao Paulo. So this is truly now a global, tumor board. So he was listening in, and he was actually just telling me that, one of the champions of the watch and wait was Dr. Angelita Habergama, who's in Sao Paulo, who he's telling me apparently is 90 years old and still has a clinic full of patients coming to see her to talk about watch and wait. So, but the question I had is, Nima, that
still doing surgery?
Not doing surgery, just seeing patients.
Okay.
That would be impressive. But that was a great review of all the trials, and for a while there, I thought only Europeans did trials on rectal cancer and radiation, because you had Swedish, German, Dutch, Polish. So, but the question I had is, where do we take this information for the stage 4 setting, right? Because we are seeing, these complete responses in the rectum, but patients who have active liver disease. And, what do we do in that scenario? Do we resect the liver and then worry about maybe seeding? Then subsequently, we've been trying to apply the same data to that population, but maybe that's not the right population to extrapolate to, particularly now when there's a protocol for liver transplant, where they're not going to accept a complete response with chemoradiation. They want the rectum out regardless. So how do we work that in?
Well, then there's also that I think it was the Japanese study looking at colorectal liver metastases, and if you're not able to resect the primary, there's no benefit in resecting the liver metastases in that study. I as a radiation oncologist, I find it unfair to those patients with limited volume metastatic disease that they have to have a surgery and a morbid surgery potentially in a clinical complete response situation. So unfortunately, I don't know of any data to help guide this non-operative management approach for our metastatic patients. I don't know. And my voice tumor board is normally on the watch and wait end of the spectrum, as you all know, especially if, our flex sig and MRIs look good, but I don't have a good answer to that. And that's a huge conundrum. I mean, short course is really, I'm really optimistic to see these short course non-operative studies, because in these metastatic patients, short course radiation makes a ton of sense, because logistically it's easier to coordinate and sandwich in between surgery and chemo and anything else they need to do. And it provides them with less time off of systemic therapy. So I'm encouraged to see these short course non-operative studies, but how that extrapolates to the actual metastatic setting is still a question for me.
Yeah, this is something Liana and I have talked about is, because we have typically also when we put in HAI pumps, right? The usual norm was that the primary had to be out, but we have been managing patients with watch and wait in the rectum and then put the pump in.
Mm-hmm.
So, so there may be a middle ground, but we don't have a good pathway for that.
No, but I have to say, either we trust that we have treated the primary tumor, and we trust that we have treated the primary tumor. Otherwise, we would not offer a watch and wait. And I think at this point, I would agree with you, Nima, and the discussions I have with Flavio. I don't know if offering the primary tumor surgery, offering surgery for the primary tumor, I'm offering any survival benefit for the patient. And I know for a fact I'm offering them morbidity. And I don't see the point. And unless you are worried and it grows back, and that's a different story. But I think in an oligometastatic disease, if your TNT has worked, it makes a lot of sense for me to treat the oligometastatic disease and watch and wait. I mean, either we believe in what we offer to our patients and we follow them, or we don't. So I don't know. I don't see like why we should not. Now, and of course, with the HI pump means not curative resection for the liver, perhaps immediately, but depends. Yeah.
I think we need Adele Cardoche to weigh in, our medical oncologist.
Yeah, the only person who sees these patients long term, by the way. So, I think, my issue with I think, Liana, you hit the nail on the head by saying that we have to trust the therapy. And I think my problem for now with short course is that we see the data for many patients that short course is not as good as long course for TNT. Even with TNT with long course, we're seeing, many patients recur locally. But with short course, the data is less supportive. And so maybe to Flavio's point about how we figure out this metastatic patients, I'm always hesitant. We don't want to do something worse for the patient. We don't do the best we can, but at the same time, it's a concern that we're offering therapy without surgery, knowing that the cancer might continue to progress, and we see this often in our clinic. So,
Adele, the Oprah study showing a benefit to chemoradiation at first really impacted your follow-up clinic, because if it was the opposite, I'd probably be following up with them, or Aaron would be.
I know.
You got the hot potato, unfortunately, for much longer.
I know.
Can I ask the Thai colleagues, what would you offer for an early stage rectal cancer, like a T1, T2, literally at the anorectal junction? Would you go ahead to an APR? Would you offer that patient radiation treatment and watch and wait for those early stages?
We offer the neoadjuvant for this kind of patient, because we try to avoid the APR.
Yeah.
And may I ask a question about the short course because in our experience, you see in my hospital we had a lot of patients come from abroad, so they don't have so much time for the treatment. Sometimes we offer the short course RT for them. Do you agree that is a good choice for them?
Yeah. I mean, for folks with logistical issues to not be there for 6 weeks, yeah, absolutely, we did the same thing.
I see. And the second question, how about the immunotherapy for the TNT? Is the role of immunotherapy?
Yeah, I don't know of any studies yet integrating immunotherapy in the TNT framework. I don't know, Adele, maybe that's a better question for you.
You mean like the dostarlimab trial? The memorial one for MSI high rectal
For
cancer?
MSI high, for sure, yeah.
Only MSI high.
And for MSI high, you would do the dostarlimab, I can never say that word, that monoclonal antibody, and you would do it for 6 months?
Is that for me the question?
Yes, Adele.
Yeah, no, it is actually much shorter. A patient responds fairly quick. The treatment, if I'm mistaken, is only 4 months.
4 months.
And I mean and it will probably be shorter moving forward, as now we realized, at least from the colon, that the niche 2 did really 3 treatments, right? 2 Nevo, 1 Epi, and they have 96% response rates. So I think the immunotherapy neoadjuvant treatment is going to become shorter and shorter.
Right, but the key to that, Adele, is that all those niche studies, remember, the only way you get past CR is by doing surgery, right?
Technically, yes, because you can't.
Technically, yes, right.
Because
So all those
it's a
endpoints are
fast
past
CR,
CR,
right? I mean, and you got to make sure they're dead.
right? So what I call that adjuvant surgery. So the
Well,
primary
yes.
treatment is the immunotherapy. The surgery is the adjuvant.
And then the surgeons have to probably follow them for the rest. I'm just kidding.
No. That doesn't happen.
So may I ask the last question that usually in US your guidelines suggest that 3-3 is preferred for the neoadjuvant. Do you substage into for the 3-3 to 3AB and 3-3 CD, the same as in the European substage for the T3?
Great question. So I'm going to ask Nima. So if we have a T3AB versus a T3C, would you change your radiation treatment?
No, I mean, the inclusion criteria in the studies did not have the granularity of MRI T3 stage for us to really use that in any clinical manner. So no, unfortunately, that kind of means the same to us. I mean, certainly once you have encroachment of the circumferential resection margin, then that certainly impacts treatment decisions, but depth of penetration from MRI doesn't necessarily change my management.
Dr. Thera, did we answer your question? Okay.
Okay, thank you very much.
Sure. It's 6:02. I know we went a little bit over, but it was an excellent talk as always from Nima and a great discussion. I know you have received the slides. Let us know if there are any further questions, and we'll see you in 1 month.
Yes, your
great.
presentation.
Thank
sorry,
you.
Justin.
Well,
Thank you. Have a good night. Or
Thank you so
morning,
much.
whatever time it is.
Thank you.
Thank you so much. And I received the presentations already, so
Okay.
Great.
good.
Thank you.
Thank you.
Okay. Bye-bye.
And